So we've talked about the different available ways that we can treat actinic keratoses beyond just focal cryotherapy in our offices. We've talked about the different modalities, their mechanism of action, the anticipated local skin reactions, and how to really temper that in some cases. I've asked each of you to bring a case to really help discuss how we can actually use things in a real life situation from a combination therapy. And I want to go to Dory Gilbert published something a few years ago where he actually used 5FU before PDT. So we did 5 days of 5FU and then did PDT, and he actually showed really a synergistic effect. So in real life situations, we really listen to the patient, we look what's going on and what degree of sun damage they have. We see if they're a transplant recipient. I really like to do the cycle therapy like Andrea Willie and Peter Lee have published in terms of dermatologic surgery. So there's a lot of things that we come into consideration, and I want to talk about some of those specific cases. So Neal, if you can pull up a case.
So Joel, the idea with some of these patients, again, you got to really give them opportunity to not only, give something for symptomatic relief, but be a little strategic. And, one of the things I always tell everyone is don't have your patients fill prescriptions on a Friday or a weekend because they'll get substituted. And the flip side is always have your patients start their course on the weekend so that the impetus or the big part of their local skin reactions is midweek, so that you can get them into the office if you have to do a quick wound check and examine them. And again, all of these different adjuncts that are useful, except for steroids, I think will continue the efficacy and still give some patients some relief. But here's a guy, he's got a lot of photo damage, a lot of AKs in different spots. He doesn't want to blow up. He doesn't want to get super red. So you kind of work with him and say, all right, well, let's treat your temples and cheeks on Monday and Thursday. Let's do the back of your hands Tuesday, Friday, scalp and forehead. You can do a couple of days, but you extend out, instead of 2 weeks on, 2 weeks off, you can do, another course of a second, set of weeks, for example. But give them, good emollients, give them something for itch, topical pramoxine, hypochlorous acid solution, I think works really well to mitigate some of those symptoms. And, again, even a little bit of, topical anesthetic like lidocaine, in local spots will help. But I think, some of these other agents and adjuncts, you really want to make sure that they're getting some relief. This was a small pilot study. I think it failed on trying to get a menthol solution out. So again, for me, the less exposure to topical steroids, the better. But you saw that patient, again, he's going to be red. He's going to have some element of healing. And again, at the flip side, some of these patients say their cosmetic outcomes are actually pretty good. Their skin feels softer. They don't feel so ruddy. They don't look so sallow. And, you and Michael and George, the same thing from photodynamic therapy. The skin, responds well from photodynamic therapy. And these adjuncts in between courses, 2 weeks of Imiquimod, for example, or 5FU would be a really good adjunct to, maintain the gains from those in-office procedures.
So, and George, your patients have tremendous sun exposure at the beach and surfing. And I remember a lot of great stories you tell me about you surfing before you get to work in the morning and you still got that mist up the nose when you start to work and you're wearing a mask. So with your patients who are getting lots and lots of sun exposure, spending a lot of time on the beach, many cases retired or just hanging out, talk to us how you actually prescribe these medications or do these combinations.
Yeah, thanks, Joel. And I've learned a tremendous amount from my colleagues, and I'm going to share my approach to some really tough cases that are pretty typical to the harder patients we see in our practice. So these are two patients who I think have, the gentleman on the left-hand side of the screen has fairly significant actinic damage. The gentleman on the right really suffers from severe actinic damage and field cancerization. You can see the squamous cell growing up there at the top, and a little basal cell. And these really require field therapy and a lot more beyond that. So let me give you my current approach to gentlemen like this who really become surgically fatigued. This is a gentleman with numerous actinics. He's had multiple basal cells and squamous cell taken off his face, scalp, trunk, and he really wants to do something. And if you stop and think about it, if we say that actinic keratoses are a chronic disease, well, why aren't we treating them continuously therapeutically? We're kind of treating them episodically 2-3 times a year if we're lucky. We're really doing nothing in between. We have great tools. We have PDT. We've got Klisyri now, we have 5-FU, and we have Imiquimod. And so maybe we should be thinking about doing field therapy a little differently and not episodically. So what I did was, as a proof of concept, I took this gentleman and I had him use daily application of 3.75 Imiquimod, or he could use 5% Imiquimod for 7 days. I gave him 2 weeks off. And then for the rest of his life, he will use once daily application of 3.75 Imiquimod for years, hopefully. It's off-label, and we don't use it in immunocompromised or autoimmune disorders. You know, if you have a transplant patient, this is not for that patient. Or a patient has autoimmune disease, we don't do it. So here you can see the gentleman I've shown you at baseline, and the middle screen shows him at the end of 1 week. Over here, he's 2 years later, and he's had 2 AKs. There's one I just froze on the nose, and he's had no basal cell or squamous cell. Got about 50 patients in sort of this proof of concept study carried out over about 5 years. And what I'm doing is I'm applying Imiquimod or having the patient apply the Imiquimod once or twice a week for the rest of their lives to keep down the actinic keratoses and stimulate the immune system. And why I chose Imiquimod, it's an immune modulator. As Neal pointed out, it activates toll-like receptor 7, which we know is really important as part of the innate immunity. And it really does a very good job at keeping down actinics and non-melanoma skin cancer. So this is what I do on a chronic basis for my patients who are experiencing surgical fatigue for the face and scalp. What else am I doing? Of course, sunscreens. Nicotinamide is proven in the New England Journal of Medicine study that was done in Australia at 500 milligrams twice a day. And by the way, niacinamide is exactly the same molecule. It's just, nicotine, or nicotinamide had a bad name sounding like nicotine from cigarette smoking. So they renamed it niacinamide. So basically just ask for vitamin B3, and you can get it over the counter. I have my patients on tretinoin in between their Imiquimod, at least daily. And I have them take vitamin D so they feel good about their vitamin D levels. And it's important in the immune health. So that's my current approach to patients with significant field cancerization. How I choose to clear them, I could now clear them with Klisyri. I could clear them with PDT. I could clear them with 5-FU. But they need something in an ongoing fashion because this is a chronic disease. So weekly or twice weekly, they're doing Imiquimod. And I will tell you that of the 50 or so patients I've been doing this with, the results are really outstanding. And their incidence of skin cancer, non-melanoma skin cancer, is minimal. I mean, it has dropped through the floor. And individuals who are getting operated on their face or scalp at least 3, 4, 5, 6 times a year. So that's my approach. It's a little bit outside the realm, but I think what it does, it addresses the issue that we're treating a chronic disease on an ongoing basis and not episodically.
So George, that was really helpful just to sort of put that all together. And Michael, can you share a couple cases with us and what determined?
Sure.
What
So I think it's really neat that you talked about Dory's study, because that was a very important study. And I'll share with you just a couple of things. So I've actually been, it's almost 20 years now that we've been talking about it. And again, I love showing this. This is, for those that don't know, was my father. And this is a typical actinic keratosis that had long drug incubation. And this is 30 days later. And I treated him for many years with that. And again, I think it worked really well. This was a game-changing patient for me. So this was a person who really never left her house. And so PDT was new, and we said, let's try something new. And this is her about 6 months later after 2 PDT sessions. She's wearing the first dress that she wore to church in almost 20 years because she had so much sun damage and so much skin reaction. And again, we've talked about this for so many years, but I think it's important that, as you said, Joel, there are things you can do before application to shorten the drug incubation time to make the patient comfortable. And this is Ricardo Ruiz Rodriguez from Madrid and Brian Zellick's study back in 2007, where they actually did a fractional resurfacing with an erbium laser prior to the application. And then there are other ways of combining red and blue light. And I just want to show you what your skin looks like in 2 seconds. So this is from Matteo Clementoni. And again, non-hyperkeratotic AKs, as you see here, 3 days after, you can have this amazingly robust, especially if you do red and blue light together. And this is the patient at 6 days. Here she is at 6 months. And here she is at 18 months. So again, I think it's really important to stress to people that you can see these, yes, robust reactions that now with what George is talking about and what we do in our office with much shorter drug incubation times. But I think using something first, whether it's a resurfacing device or using a 5FU type thing for a few days can actually help the penetration better, and it can help make the patients better.
So Michael, you do more clinical trials than really anybody I know. And I know that, the Klisyri data and having participated in that is very exciting. Can you take us through what's on the radar in terms of actinic keratoses?
So there is a very large daylight trial. So daylight PDT in the US is not approved. And again, if you do daylight PDT, I think it's important to remember the reimbursement for the light. You get reimbursed for the light. You get a code for getting the drug, but you get reimbursement for the light. So sending somebody outside, you can't actually bill for that. So there is a very large study going on with daylight PDT, and it's so far it's a several-year study. So far everything is looking good. The patients have responded well. When you use the methyl version, you actually take your curette and you actually turn it to the other side, not the sharp side, and you scrape off the keratotic part so you can, the drug can get absorbed better before you apply it, and then you occlude it, and then you send the patient outside. I think there are several drugs that are on that have been at least applying to get into phase 2 US clinical trials from outside the US. We have been approached by several companies to start talking about potential. They are all on the pending side because of the COVID situation of the last year of not being able to get into the US. So we probably won't see any new AK trials that I'm aware of until perhaps the end of 2021 or the beginning of 22. Neal and George may have something different on that. And I think that we have a new drug, and we're going to have to see the best way to use it, and we're going to have to see how it actually works in the real day. Because again, I think we've had drugs topically, and they've had to be tweaked and they've had to be rethought of and how we're going to use them. But this one, Klisyri looks so promising, that it's going, we're all going to use it, and I hope it does really well.
Just as we wrap things up, I asked Neal specifically to talk about the vitamin B3 data. The New England Journal of Medicine study from Australia was a year-long study.
Based on the results of the on-track study, we now have a formulation of combination with polypodium leukotomas that is an easier chemoprevention and photoprotection strategy for daily use. There's not the risk of flushing like with plain niacinamide at that dose with nicotinamide, but at least with more commercially available, nicotinamide plus polypodium leukotomas, it may be a little bit more comprehensive combination therapy that can be used on a daily basis, and then use the plain polypodium leukotomas episodically.
So George, and then as a final thought, I asked you specifically, talk a little bit about topical retinoids as secondary prevention strategy. There was a VA study that Mark Naylor did a number of years ago. And some of the data showed that some of the AKs were cleared, some of the areas that had AKs developed into basal cell as well as squamous cell, which was a little conundrum. But we recommend regularly retinoids topically for our patients in between therapy, and talk to us about the formulations or really the data.
So as far as retinoid therapy, let's talk about topical and let's talk about systemic retinoids. So in terms of topical retinoids, Al Kligman, who is the pioneer of retinoic acid tretinoin, we now have come to learn as Retin-A, did a study way back in the late 70s where he took the 0.1% and treated patients for a period of 6 months and showed a marked reduction in actinic keratoses. So we know that retinoids, vitamin A derivatives, normalize cell growth and differentiation, and that was really why he started it. And so there hadn't been a lot of interest in retinoids topically over time as far as field cancerization, et cetera. And of course, with the advent of Renova back in the 80s, as an anti-aging, anti-wrinkle formula, we forgot all about actinic keratoses. But when patients were applying it, they did get the benefit of keeping down their actinic keratoses. Currently, meta-analysis looking at the effect of topical tretinoin and topical retinoids in general have really not shown a defined benefit of preventing non-melanoma skin cancer. But it's kind of like one of those things we do. We inherently suspect it works. Our gut tells us it works. It does good things, if only to reduce wrinkles and fine lines and dyspigmentation. And if it gets a benefit on the actinic side, so be it. The flip side of the coin, the real retinoid I've come to use over the last 20 years has been acitretin, which is a systemic retinoid. And I use it for patients who are suffering from not just field cancerization, but patients who are really suffering from surgical fatigue. As the graphic picture I will show you with this woman who's got numerous eruptive squamous cell carcinomas and KAs on her legs, this gal is a woman who absolutely needs retinoids, or individuals who, there are 3 to 6 basal cells and squamous cells or more a year. Those are people who I would really think about putting on a systemic retinoid such as acitretin. I start with 10 milligrams a day. We do lab monitoring initially at baseline, and of course we follow it up at a month and make sure they're okay, because it can bump in 2/3 of patients their triglycerides, and about equal number have a bump in their LFTs, although it's mild. I don't get excited about the LFTs until they go over 200 to 300. And what we also do is we encourage them not to drink, because again, this molecule is metabolized by the liver. Our sweet spot is usually 25 milligrams a day, and it dramatically reduces the incidence of basal cell and squamous cell carcinomas, as well as actinics. And the patients will be on it for lifelong. Most patients, I would say 90% of my patients, tolerate it very well. We do give them drug holidays, but 2 things need to be understood. Number 1 is that this is not a treatment for squamous cell or basal cell, because once that tumor is established, you have to remove it via some procedure, surgical procedure, but it does prevent them. Number 2 is that once you stop the drug, the squamous cells and basal cells, after some period of months, will start surging back. So this is a lifelong treatment. You have to explain that to your patients. The biggest pushback I get is limiting their alcohol intake, which I tell them you can have, according to all the data, a maximum of 2 drinks a day. And that's it. So that's for those of you out there who have patients giving you pushback about alcohol. That's a caveat. So my biggest use of a retinoid in serious situations is a systemic retinoid such as acitretin, but certainly daily use topical retinoids, I feel, and I personally use a topical retinoid on a daily basis, having had 3 basal cells and an actinic, and I feel it's benefited me.
I think we've covered the full gamut of people with actinic keratoses and people with complicated and significant actinic keratoses and widespread actinic keratoses, face, scalp, hands. And it's really been wonderful to have the 3 of you join us. And thank you all very much for joining us for another episode of Scientifically Speaking.